Hey everybody, it's the Dr. Nurse here with drnurse.com. Today we are going to talk about one of my all-time favorite subjects to teach, electrolytes. And I've already done a short video on IV fluids and the difference between isotonic, hypotonic, hypertonic. So you can check that out. It's up on the site. It's also on my YouTube channel. But we're going to talk about always important electrolytes. So you're going to see these electrolytes on your BMP. So we're going to talk about some things that that I have seen maybe in a few videos that I've been watching that aren't true. We're going to correct those things. We're going to talk about the normal values that you need to know, the major contributors to imbalances of electrolytes. And then I've also got a study guide that lists out the most important unique signs and symptoms of each electrolyte. So let's get started with sodium. So memorizing electrolytes and their signs and symptoms and what they do and what makes them high, what makes them low, memorizing that is not going to get you anywhere. So I try to simplify things. And so when I say sodium, I want you to automatically think of nerves. Okay, I've got a picture of a neuron there, that green, I think that's a neuron anyway. So I want you to think sodium and nerves, okay? And the abbreviation for sodium starts with an N. So that's going to be easy to equate sodium with nerves, okay? And these normal values, y'all, they're going to vary from, program to program, from facility to facility. But these are the ranges that I teach my students. So normal sodium level is going to be from 135 to 145. The main job, like I said, of sodium, conduction of nerve impulses. So when you think of sodium, think of nervous system, think of nerve impulses. Also, it's a major contributor to serum osmolality. Okay, remember serum osmolality is the concentration of particles that is within your fluid. So there's the big three contributors to serum osmolality. That is sodium, proteins, and glucose. Okay, the more of those things that you have within your fluid, the higher the serum osmolality. All right, so hyponatremia, a low sodium level below 135. What is the main contributor? Well, it is going to be a fluid volume excess of any reason, okay? A fluid volume excess we know can be caused by congestive heart failure. It can be caused by kidney failure. Anything that causes a fluid volume excess causes what we call a hemodilution, and that is going to make your sodium appear low on your BMP. Another big one is SIADH, when you secrete too much antidiuretic hormone from your posterior pituitary, that causes a big fluid volume excess, so that dilutes your sodium out. What do we worry about here? Well, obviously nervous system, sodium, nervous system. We worry about seizures when sodium gets really, really, really low. And I remember I tell my students this story because I think that stories from real life kind of enhance the topic and really kind of help drive it home and help you remember. But I remember when I was working in an ICU several years ago, we would have a person that would frequently be admitted to the ICU because they were having seizures. Well, what this person was doing was drinking tons and tons and tons and tons and tons of water, and therefore diluting their sodium out. Now, they didn't know that they were diluting their sodium out. They just knew when they drank a lot of water that they started having seizures and they would get to go to the hospital. Okay? So that's a big thing that we worry about is seizures, because when you dilute out that sodium, you're dropping your serum osmolality. And when your serum osmolality is low, that's in the vascular space, that means that the osmolality of your cells is now higher than that of your serum. And so fluid goes to places of higher concentration. So now if you have a very low serum osmolality, such as when you've diluted your sodium out, fluid is going to leave the vascular space and enter the cells. And when it does that, it can cause cerebral swelling and cerebral edema and seizures. Okay, so remember that. So the very opposite is going to be true for our high sodium levels. So a hypernatremia, main culprit here is going to be a fluid volume deficit or hemoconcentration. Okay, so people that come in dehydrated, they've been vomiting for a long time, for whatever reason, their sodium is going to appear very high on their basic metabolic panel, on their BMP. Okay. Next, this is my all-time favorite because I love cardiac. Potassium. So the normal value that I choose to go with here is 3.5 to 5. Like I said, that can vary from program to program and hospital to hospital. This just gives you a general idea. The main job of our potassium, the majority of it lives inside the cells. Somewhere around 70% of your potassium lives inside the cell. Okay, whereas sodium lives outside, potassium lives inside. So that kind of gives you a framework for how the sodium potassium pump works, right? So the vast majority lives inside the cells. Absolutely essential for cardiac function, for muscular function, okay? Hypokalemia, when we talk about a low potassium, what causes the vast majority of hypokalemia in our patients in the hospital is those loop diuretics, okay? Lasix or furosemide. You know, when you go to take NCLEX, they're going to ask you the generic names of your drugs. So that's just a little tip from the doctor nurse there. Know the generic names of your drugs because they're not going to say Lasix, it's going to say furosemide. Not hemodilution. Hemodilution is not a huge contributor to low potassium because it lives inside the cells. Okay, hemodilution contributes to our low sodium, but not necessarily potassium. So those loop diuretics and insulin too. Insulin, every time you go give your diabetic patient a subcutaneous injection of insulin, we're pushing more potassium back into the cells and we're making them more hypokalemic. Another thing, if you have a COPD patient and you're giving them a lot of breathing treatments, a lot of those beta-2 agonists, you know, nebulizer treatments, those are the same thing. They push potassium into the cells, and you're going to worry about hypokalemia with those patients. Major contributor to a high potassium is going to be renal failure. Okay, our renal failure patients, when they have a really, really low glomerular filtration rate, they can't filter potassium out like they need to. Okay, so we really worry about hyperkalemia in our renal failure population. Next, calcium. All right, so I teach my students that calcium calms, okay, and we'll see why. Check out the little study guide that I've posted to the site that goes over the main signs and symptoms for each of these imbalances. The normal value for calcium that I choose to go with, let's make it easy, 8.5 to 10.5. All right, so obviously the major job of calcium is it forms bones and teeth. 99% of it is inside the bones and the teeth. It has a major role in the formation of prothrombin, so it plays a role in blood clotting. Also muscular contraction. Main culprit to a low calcium level is renal failure. All right, and there's a few reasons behind this. Your kidneys have a big part in vitamin D synthesis, and you know that you have to have vitamin D in order to absorb calcium. So if the kidneys aren't synthesizing vitamin D like they should, your patient's going to be hypocalcemic. Another reason we're going to talk about when we get to phosphorus. The kidneys, when they're failing, they can't get rid of phosphorus, and so they hold on to phosphorus. Well, in turn, calcium goes down because those two electrolytes have an inverse relationship. Hypercalcemia, main contributor, going to be hyperparathyroidism. Your parathyroid glands secrete PTH, or parathyroid hormone, to try to get calcium back up. Okay, so if you have overactive parathyroid glands, then you're going to see a hypercalcemia or an elevated calcium level. All right, magnesium. So calcium calms and magnesium mellows. Normal value here will go with 1.5 to 2.1. Magnesium also has a big role in cardiac rhythm, okay? If your patient goes into like a dysrhythmia, first thing when you call the provider, they're going to say, what's the potassium? Potassium's okay. They're going to say, what's the mag? And mag also has a big role in neuromuscular contraction, in facilitating that nerve impulse to cross that junction and actually make the muscle do what we want it to do. So low magnesium contributor, alcoholism actually. So alcoholism is a big culprit in patients coming in with low magnesium. And then there's renal failure again with the hypermagnesemia. So renal failure patients are going to retain magnesium. Then phosphorus. So phosphorus normally runs 2.5 to 4.5 or 2.5 to 4.5. Main jobs of phosphorus, it plays a big role in cellular metabolism and formation of bones. 85% of it, in fact, is stored in the bones. So low phosphate or phosphorus, contributors, malabsorption syndrome. A lot of folks that have gastric bypass, or they have part of their intestine removed or something like that. They're not going to absorb nutrients like they should. Diarrhea and acids. But what I want you to really take away from this is that phosphorus has an inverse relationship with calcium. So anything that makes calcium go up is going to drop the phosphorus level. That's really, really important to remember. And then hyperphosphatemia, major contributor, here we go, renal failure. Okay, that's why we can't give our renal failure patients a big Coke to drink because of all the phosphorus. Okay, renal failure patients cannot filter out that phosphorus like they should. And then finally, chloride. Chloride seems to be kind of maybe the forgotten electrolyte, but it's important. So our normal chloride level is going to be 95 to 105. Plays a big role in acid-base balance. Hydrochloric acid, does that sound familiar? So hydrochloric acid obviously has chloride is a big part of that, so it plays a big role in acid-base balance. Also fluid balance, okay? Sodium and chloride, they travel around together, okay? Sodium has a positive charge, chloride has a negative charge, so therefore they're attracted to each other. And so if sodium plays a big role in fluid balance, so does chloride. When chloride levels drop, the major contributors there, prolonged vomiting, diarrhea, possibly, and states of alkalosis, because it plays such a big role in acid-base balance. So remember, low chloride, alkalosis, all right? And then hyperchloremia, obviously hypernatremia, because they travel around together. Chloride and sodium, they go together. So where sodium goes, chloride goes. And then vomiting and dehydration. And so basically vomiting and severe dehydration would lead to a state of hemoconcentration where sodium would be elevated. So naturally chloride would be elevated in those states also. And that is it for this real quick electrolyte wrap-up. Go ahead and follow me on Instagram. I'm on Twitter. Subscribe to the YouTube channel. We're going to be adding videos every Monday. We're going to call them Monday Mythbuster Movies. And so the big myth that we busted today was potassium or hypokalemia is not really caused by hemodilution. And then go ahead and check out the accompanying study guide of electrolytes that I've got up on the site at www.thedoctornurse.com. And again, thanks everybody for listening, and I will see you here again soon.